Good morning or afternoon or evening to you, wherever you may be. My name is Brennan Mandel. I'm the Director of the Innovations Program at Jhpiego, and I would like to welcome each of you to the first of the webinar series, Ideation to Impact. In this webinar, we'll be focusing on the design considerations for maternal and newborn health technology for global health settings. We know many of you represent a vast array of disciplines, experience, and expertise, and you've joined today because of your interest in and commitment to maternal and newborn technology. And for that, we thank you for joining this session. Jhpiego has chosen to convene this webinar to capture some of the momentum and diversity of expertise, as well as to surface some of the exciting work and challenges that are happening. We believe that the meeting of unlike minds and greater collaboration is really the key to all of our success. I would like to thank Jhpiego Innovations for helping develop and organize this webinar series. It is now my honor to introduce my colleague, Dr. Harshad Sanghvi, as the moderator for this session. He will introduce the panel of speakers and the content for this kickoff to the webinar series. Enjoy.
Hello. Welcome to the Innovations Program webinar series. I'm Harshad Sanghvi, Vice President for Innovations at Jhpiego and Medical Director. We're delighted to bring some very exciting speakers who will stimulate a spirited discussion. We are today in 2015, the year by which we were to achieve the very lofty Millennium Development Goals. Sadly, only a handful of less developed nations are on track to meet both Millennium Development Goal 4 and 5, and maternal mortality and newborn mortality and morbidity remain unacceptable. The world is coming together again to set more goals, and by all indications, we will set unprecedented goals. One such goal may be achieving 50 by 2035, that is 50 maternal deaths per 100,000 live births. I think it is right to challenge ourselves with unprecedented goals, but to reach them, we will need unprecedented commitment, new partnerships, and more importantly, innovation. Our webinar series will focus on innovation, first in design or early stage development, then on overcoming market viability and public health effectiveness challenges, and finally on delivering this innovation to women and newborn that need it most. Our goal is to get coverage at scale, quality at scale, and impact at scale, while ensuring that innovations remain affordable and acceptable. For 40 years, Jhpiego has worked to prevent the needless deaths of women and families in developing nations. We understand that to bring about a faster pace of change, we need new and creative ideas and technologies. Today, we'll focus on how we can better design our solutions to meet these persistent and emerging needs. We can certainly learn a lot from our successes, but we must also seek to learn from our failures. I'm delighted to introduce now the four panelists. The first one is Jeffrey Smith. Dr. Jeffrey Smith is an obstetrician and gynecologist and public health practitioner with 20 years experience, clinical and public health in developing nations across Asia, Africa, and Latin America. Currently, Jeffrey is the medical health team leader at MCHIP at Jhpiego, based in Washington, D.C. He's also assistant professor at Gynecology and Obstetrics and International Health at Johns Hopkins University School of Medicine and Public Health. The last 10 years, he has spent lots of time in Asia, in Nepal, in Afghanistan, and Thailand. And I credit Jeff with rebuilding midwifery in Afghanistan. Our next speaker will be Rebecca Richards-Kortum. Rebecca is Director of RISE 360, Institute of Global Health Technologies, and Stanley C. Moore, Professor and Chair of Bioengineering at Rice University. Over the last 2 decades, Rebecca has focused on advances in nanotechnology and in microfabrication to develop novel, low-cost sensors to detect infectious diseases at point of care, including cryptosporidium, malaria, and HIV. And as part of Beyond Traditional Borders educational program, her team is currently working to develop a new generation of highly effective, affordable technologies to improve pediatric care in low-resource settings. Our third panelist is Erica Kochi. Erica co-founded and co-led UNICEF's Innovation Unit, a group that is tasked with identifying, prototyping, and scaling technologies and practices that improve UNICEF's work on the ground. The Innovation Unit supports UNICEF's 135 plus countries in the practical applications of design and technology to stimulate and strengthen international development outcomes. Erica also serves as the innovation advisor to UNICEF's executive director. And our last panelist is Robert Miros. Robert is the CEO and founder of Third Stone Design. Robert established Third Stone Design in 2005 so that needs from around the globe could be considered when embarking on new product development endeavors. Robert has been active in product development arena for 20 years as a consultant, in-house engineering leader, and field marshal for greater design. Prior to founding Third Stone, Robert held VP and director positions with medical device, alternative energy, and consumer product companies. So Jeff will be our first speaker, and Jeff, you're on.
Great, thanks very much, Harshad. And good morning and afternoon to everyone. It's a great opportunity for me to speak to you all, and I want to speak a little bit about looking at the horizon of maternal health and understanding our landscape, and really seizing the opportunities that we have. The global attention is still on maternal and newborn health, and there are numerous strategies and global consensus statements bringing us all to focus on the issue of maternal and newborn health. We've made great progress in the last 20 years, and there are new lofty goals that we have to set our sights to. And as we go forward, going that next mile and soon to be that last mile, under the banner of ending preventable maternal mortality, we really need to improve our creativity, up our capacity, and drive towards completion. So the next slide. I want to take us back for a moment to a study that we did a couple years ago, which was a survey in 37 countries that looked at the implementation of what many of us would say is one of the most brilliant innovations in maternal health in recent years, the advent of the use of misoprostol for the prevention of postpartum hemorrhage. And there have been lots of pilots in the use of misoprostol, and this is data from 2012. And if we look above the heavy black line at the green bars, we look to see many, many countries, more than 15 countries that have piloted misoprostol for prevention of PPH at home birth. But if we look at the purple bars, we see very few countries that have actually taken it to scale. And we need to continue to ask those questions. If we have an innovative and important technology, what are we doing to take that to scale? There could be many reasons for us to imagine why this hasn't gone to scale, but we need to examine and consider those reasons as we develop our interventions. Next slide. I also want to bring us back to what Harshad said a moment ago. Where are we headed? If we look to the left or to the right of this slide, we see the convergence of mortality decline lines. We see that the global strategy is going to be to achieve a global maternal mortality ratio of less than 70 by the year 2030. As Harshad said, less than 50 by the year 2035. But for us to achieve 70 by 30, we have got to up our game. We've got to come up with new strategies. We've got to come up with new approaches that are really going to help us get there. But also important, in the next slide, is our issues of measurement. What is going to be different as we go forward? What are we going to do that is unusual? Next slide. In the next 5 to 10 years, the focus is really going to be on issues of quality, equity in coverage, metrics, and comprehensiveness of care. We have really we're on the verge of a paradigm shift. We've worked very hard to convince families and women that they should come to facilities for delivery, and now that they're coming to facilities, we have got to convince them that they've made the right decision by improving quality. The approach in the last 20 years, or the norm, has been delivery at home. The new norm should be delivery with a skilled provider in a facility. But in order to achieve that, we've got to make that shift towards quality. We have to reach every woman and every newborn. And we have to begin to dissect our approaches to make sure that we're addressing equity and getting to all subsegments of the population. But in order for us to know whether we're making these achievements, we've got to have better metrics. And this is one of the most important untapped areas in global maternal health and newborn health. We don't have good metrics for our intervention. And we need to improve the comprehensiveness of care. And I don't just mean comprehensive emergency obstetric care. I mean dealing with that sick preeclamptic and that sick newborn who needs additional resuscitation. We've got a number of good interventions for getting us those first few steps, and we need to start thinking about more complex cases. Next slide. Other important themes are going to be strengthening of antenatal care and postnatal care, especially with the purpose of impacting the intersection between maternal newborn health and infectious disease. In many parts of the world, infectious diseases such as malaria, HIV, tuberculosis are major causes of maternal mortality. And other infectious diseases, such as sexually transmitted infections and syphilis, have big impact on preterm birth, maternal and newborn infection, and other diseases. So the last 10 years or 20 years has been a focus on intrapartum care, and that's been fundamentally important. And I think while we continue that focus on intrapartum care, we need to reach out both before and after the birth and strengthen the platforms of antenatal care and postnatal care. And it's really some of these infectious diseases that will be addressed in those platforms. And then another area that I think will get a lot of attention in recent years, or in coming years, is preterm birth. Many of us have recognized that preterm birth is actually the #1 cause of newborn mortality, but preterm birth is a challenge that cannot be addressed by the newborn community alone. Many of the interventions for both the management and the prevention of preterm birth are in the hands of the maternal health community. So this is an area where we have to work very collaboratively with our colleagues in the newborn community to address both the prevention, the management, and the care of the preterm newborn. Next slide. Just recently, just about 2 weeks ago, the WHO issued new data on the causes of maternal mortality. And this is a complex slide, but I invite you to look at this paper in The Lancet. And it looks at the causes of maternal mortality spread across different regions of the world. And we see that postpartum hemorrhage is still a major cause of mortality, but we also see that indirect causes are surprisingly high. And as we look forward, we have to take this information about the causes of maternal death into the picture. And my final slide. These are the new indicators that are proposed for measuring our progress as we go forward. Maternal health has been lagging behind other fields such as child health, HIV, family planning, in terms of our indicators for measuring both quality and coverage for maternal health. And these are the indicators that have been proposed recently by WHO. And I strongly believe that understanding these indicators, putting them into practice, and understanding and taking action on the data that will come from them is a fundamentally important next step. So putting our minds and our creativity towards how we collect these indicators how we transmit and use the information, and how we can make decisions based on this information is going to be fundamentally important. So I think there are new challenges that face us. I think there are new opportunities. And I'm quite certain that the creativity, the ingenuity, and the innovation that a group such as those who are listening to this conference will be able to help us take that next step. Thank you.
Thank you, Jeff. That was excellent. I think you've set a very good stage for the discussion. Our next panelist is Rebecca Richards-Kotum from Rice University. Rebecca, you're on.
Thank you so much. If I could have the first slide. So I was asked to talk about two things. First, how the maternal and newborn health community provided critical information that guided our technology development efforts at an academic setting, and then to share some of the challenges and lessons learned through this process. And so I want to start with how that community influenced the projects that we took on. We were, of course, influenced by the Born Too Soon report, which outlines all of the challenges that premature babies face. Next slide. But we were also very influenced by our clinical collaborators. We work very closely with Queen Elizabeth Central Hospital in Blantyre, Malawi, with the pediatricians there. And in particular, Liz Molyneux, who is pictured in this slide, has really been an inspiration and great source of ideas about challenges where technologies could make an impact in improving outcomes for newborns. Next slide. We've spent a lot of time shadowing both clinicians as well as nurses in the nursery at Queen Elizabeth Central, trying to understand just what are the day-to-day challenges that they face in delivering care. And one of the challenges that they presented to us was the challenge of respiratory illness and respiratory distress syndrome in premature babies in particular. The next slide shows the impact that technology had when it was introduced in the United States. So premature babies who have respiratory distress syndrome can be effectively treated with a technology called continuous positive airway pressure, or CPAP. And when this technology was introduced in the United States in the early 1970s, what we found was that the survival rate for premature babies went from 25% to 70%. Before CPAP was introduced in the United States, the standard of care was simply nasal oxygen, and at that time, only 1 in 4 babies with respiratory distress syndrome survived. And unfortunately, in the tertiary hospitals in Malawi, nasal oxygen is the standard of care for treating babies with respiratory distress syndrome. And so the clinicians there challenged our program to develop an affordable technology to be able to deliver continuous positive airway pressure, or CPAP therapy. The next slide shows the result of that design effort, which was begun in the fall of 2009. We engaged a team of senior engineering students to work as part of a year-long capstone design effort to develop an affordable CPAP system. And you can see them here in the spring of 2010 with the prototype that they developed. The next slide shows the I apologize, something happened with the colors in this slide. They didn't quite come through when it was transmitted. But what's plotted on the y-axis is the pressure that is delivered by 2 different bubble CPAP systems, one developed by our students and the other that's used for clinical care at Texas Children's Hospital here in Houston, versus time on the x-axis. And the point of this graph is to show that the prototype, which was made by our students, delivered the same therapeutic flow and pressure as the device that was used to provide clinical care here in Houston. But the cost of their device was reduced from $6,000 for the commercially available devices to about $150. Next slide. Our student, Jocelyn Brown, shown here, was able to take this device back to Queen Elizabeth Central Hospital in Malawi and demonstrate it for the nurses and pediatricians in the neonatal ward there. And they gave her lots and lots of really helpful feedback that made the device easier to use. And so Jocelyn came back to Houston, and on the next slide, she was able to work with our colleague Robert Miros at Third Stone Design, whom you'll hear from later, to make some significant improvements both in the usability and the level of robustness of this device. And you see here the prototype that was actually brought into clinical evaluation at Queen Elizabeth Central Hospital. On the next slide, you see Jocelyn together with Dr. Molyneux and the 4 nurses who were hired as part of a USAID-funded study to evaluate the efficacy of that device in the neonatal ward at Queen Elizabeth Central. The next slide shows a photo of that device actually being used to treat one of the babies who participated in the study. Babies were eligible to participate if they had severe respiratory illness, and in the opinion of the treating clinician, they would benefit from treatment with CPAP. If you look at the next slide, you'll see the results of that study. What we did was we compared outcomes for babies who were treated with CPAP. The survival rate for those babies is shown in the blue bar on the graph on the right, to those who were treated with nasal oxygen. And very similar to what happened when CPAP was introduced in the United States, we saw the survival go from 23.5% for babies treated with nasal oxygen, the local standard of care, to 64.6% for babies who were treated with CPAP in that study. Based on those results, we were able to work with USAID. Go ahead to the next slide. We were able to work with USAID, and again, I think we had some translation problems with the slides, to begin to roll out the technology to all of the government-supported hospitals in Malawi, including the 4 central hospitals and the 28 district hospitals. We've just completed the rollout to the central hospitals and the first third of the district hospitals. The next slide shows the next generation improvement in the technology, and I know Robert will talk more about this because he led the design efforts for the Pumani CPAP device, which is being made by Third Stone. The next slide shows some of those devices that were made by Third Stone in support of the rollout to the district hospitals. The next slide shows the focus of our current efforts in partnership with Queen Elizabeth Central. We're working to develop a suite of technologies that we call the Nursery of the Future that would provide a cost-effective way to comprehensively meet the basic needs to improve newborn survival, including keeping babies warm, providing treatment for neonatal jaundice, supporting any respiratory difficulties that they have, providing basic laboratory diagnostics. And in parallel, we're developing a similar suite of technologies to address maternal health needs as well. Next slide. This is very much a partnership both with the medical school in Malawi, but also Malawi Polytechnic, which is the only engineering school in Malawi. They're currently introducing a bachelor's degree in biomedical engineering, and we're working very closely with them to include the same sort of project-based engineering design as part of their curriculum to help meet the local healthcare needs, as well as to provide collaborative opportunities jointly between Rice and the Polytechnic. Next slide. And this shows actually the results of some of our initial collaboration with Malawi Polytechnic. We had previously worked to design a low-cost set of phototherapy lights at Rice, and we transferred that technology to Malawi Polytechnic, where Rodbo Bacolo, the engineer that you saw in the previous photograph, actually improved the design and has worked to manufacture enough of those devices to disseminate to all of the district hospitals that are participating in the rollout of CPAP. And I think the next slide is the last slide. And these are some of the key lessons that we have learned through this interaction with our partners in Malawi. And the first is that while I've described a technology that was successful, there have been many, many times where our initial design really did not fully meet the needs of the users and the clinical need. And really we've learned so much by looking at what caused those designs to fail, and being able to share those with the students that are engaged in the design has helped us to get it right more quickly. And we've learned to really listen to the potential users and their feedback about the technology. They are able to tell us very quickly what is likely not to work well and what needs to be improved. We very much have a focus on getting the technologies out of the lab early, and our slogan is, if it never leaves the lab, it's really not innovation. We recognize that that cannot happen without partners, and those include both clinical partners as well as private sector partners, and I'll let Robert tell you more of that story. And beginning to roll out the CPAP device, we are humbly learning the lesson that implementation takes time to get right, and scaling it requires a lot of communication between the technology developers and the on-site users, and training and retraining. And I think one of the big lessons that we've learned in that implementation is just how poor some of the communication currently is between the clinical teams that are caring for moms and the clinical teams that are caring for babies, and that newborns often get lost and suffer as a result of those communication gaps. And it's important to put efforts in place to strengthen that communication at the same time that we're developing technologies for both of those clinical settings. And the final lesson that I think is really important in scaling and implementation is to think about who is the customer, who is actually going to purchase these technologies. It's very different than who is going to use them. And thinking about that from the beginning is equally important as the user in being able to successfully scale. So thank you. I'll stop there and happy to take any questions at the end.
Thank you so much, Rebecca. I think that's a very, very fascinating description of not only development of the technology, but the development of the capacity to continue to build the technologies in developing nations. So thank you so much. Our next panelist is Erica Kochi from UNICEF. Erica, you're on.
Thanks very much. So I'm talking, my example is specifically around sort of more child health, but I think that as we task community health workers with more and more responsibility, I think this will very quickly, and we already see it moving towards maternal and newborn health. So I want to talk a little bit about how design thinking is really relevant to design of maternal and neonatal and child health programs, but also to design of technology. Next slide. We all know that 3/4 of the deaths out there are attributed to 3 diseases: pneumonia, diarrhea, and malaria. Next slide. And we also know that through many years of research, we've seen that community health workers really can reduce their mortality in these 3 areas. Next slide. Yet implementation, country by country, is very, very different. Some countries allow community health workers to do one thing but not another. So designing a one-size-fits-all program or one-size-fits-all technology is basically next to impossible. Next slide. So what are the benchmarks for success around this? These are sort of the 8 things that WHO and UNICEF have laid out, and I mean there's nothing particularly surprising about them. Next slide. So what does this look like normally at a country level? So for coordination and policy making, we need to make sure that the policies are in place at sort of the highest level. We need to make sure that there's money to finance this. We need to make sure we have people within the system. We need to train them. There needs to be medicine. You can't have community case management without that. And the people who are delivering this need to know. We need to develop guidelines for them about how to deliver these services or how to refer. Obviously, they need to know what they're doing, so we communicate and mobilize socially. And we supervise them, and at the end of the day, we make sure that they're putting in information so we know if we're doing a good job or not. So all of this is kind of seen from the top level down. And in a lot of countries that I've worked with, this is sort of how it goes. Next slide. So what happens when you insert design into this process? Next slide. So I'm going to give an example of a program that we looked at both in Uganda and Senegal, where community health workers actually have quite different roles. In Uganda, they're very largely volunteer and often sort of don't have high levels of literacy. Next slide. And in Senegal, they're actually paid small amounts by the government, and they're part of the formal health system. Yet they still sort of have similar challenges. Next slide. So instead of thinking about all of those 8 things from sort of the top down, we sort of took it the other way and started thinking about it from the people within the system. And because we're really trying to, it's a community health worker at the end of the day that's delivering these sort of life-saving treatments or referral, we looked at their journey. But theoretically, you could be able to place the emphasis on anyone within the community. And we're really looking at sort of their journey, not just in terms of the guidelines of, assessing, treating, diagnosing, and referring, but actually like from the point that they're recruited, how they're trained, how they deliver these services, and sort of what are all the factors and sort of the communication channels that need to be in place to best enable them to do their job. I think, when we think about, especially because public health usually works in verticals, we usually think commodities, we think diagnostics, we think supply chain, we think information, but we don't think of them as an integrated system. We think of very much of them as a vertical. So this kind of shows, when you think about an ideal community health system, it should look something theoretically like this. Next slide. So what we did is within these 2 countries, we did a lot of research, sort of anthropological and ethnographic research. We looked at the tools they were using, the workflows that they were going through. We did one-on-one interviews with them. We observed sort of their daily routine. And we did this with sort of mainly with community health workers, but also with all stakeholders in the system. And I think this is the core tenet to all of UNICEF's work is design with the user, prototype things right there, and failure is great. We fail most of the time, but learn quickly from that failure and move on and build on that failure. Next slide. So what are some of the insights that we had, which I think can really point towards a better design of community health programs that are much more intuitive and really support the end user. It's not sort of us sitting at sort of the capital level with the Ministry of Health and other partners saying, yes, we must get that information, or we must pull, or we must give them this, we must give them this. Let's look at what their lives are like and what we can do to support that. So we know, for those of you who have worked in the field, all of the job aids are, that while sometimes they're great, they're kind of fragmented. Next slide. So let's look at what would a connected system look like. And this is something that would have to really be done at a country level. But let's look at a connected system which where the training materials, the medicines, the diagnosis tools are all combined into one integrated approach. Next slide. The other thing is the carrying solutions. I think we often think, oh, well, we'll just give them bags and they can carry their things around. Or let's just give them bulk boxes, not really thinking about where they treat people or how they diagnose people. Next slide. So this is a concept that we came up with where you actually have the diagnosis tools sort of very apparent, but you have the medicines very hidden, for example, and you could put it over your lap. Now this is just a prototype, but one of the things that we observed was that people, if their child is sick, they want medicine regardless of, and they don't necessarily trust the diagnosis, even if that's not what they need. Next slide. The other thing, and this is my personal pet peeve, is around data. I see so much data collected from community health workers, and whatever NGO is paying more seems to to get the data. And they're community health workers. I'll see they'll have 5 phones. One is for one NGO, one is for another one is for another, and whoever's paying them for the data is usually the data that they collect. But they're not using their data, right? They're just sending it up the system. Next slide. So we need to really be thinking about what data do we actually need, and can we use these one-way data flows into sort of effective feedback loops. So while they're doing their job, data is actually being collected as a byproduct of their job and not as something that they have to spend hours and hours on, either fabricating or entering at the end of the day. Next slide. Also training. I think training is a really big incentive because they're largely a volunteer force, and that's often the way that they get paid. It's also they feel that that people are investing in them, and it's sort of a recognition. And I think it's a very powerful thing. But we need to think beyond sort of gathering people all together on a quarterly or once-a-year basis. Next slide. And think about how we can continuously train and how we can use groups. If people do have cell phones, how we can use sort of the group mentality to figure out who the star performer is and get them to be on a career path to become almost a trainer within their community. Next slide. And I think one thing that we're going to face, we're already facing it in the child health realm, but we'll definitely face it in the maternal and neonatal health realm, is sort of incentives. Most of these are a volunteer force. They are usually taking away this competes with their job, which is usually agriculture related. They're using their own phones often, which is fine, but they're using sort of the credit on their own phone. And while they take great pride in their resources, they're not really giving enough incentives or a career path to move forward. Next slide. So we need to think about how to sort of give this, I think this idea of recognition and trust really came through in all of the work that I've done around the world with community health workers, and I think we really need to sort of motivate that, whether it's an emblem, whether it's actual sort of payment for work performed, etc. Next slide. And then obviously supply chains. I think we're seeing a tremendous amount of work in this space already. But it really, without that necessary supply, does undermine the level of trust that they need to be effective in their communities. Next slide. So we need to be thinking about, and I already see a lot of movement in this space, how do we better partner with private sector companies that are getting their product out there, not just in sort of a CSR kind of way or a charity way, but in a way that they could actually make money from it, understand sort of consumers in the last mile better, and really develop more meaningful services and products for them. Next slide. So when you think about the framework, which is sort of you can see at the bottom with the community health worker at the center, I'm just taking it back to sort of at a national level. This is sort of a way to look at, well, what's at the Ministry of Health level, what are the basic sets of commodities that I'm using, diagnostic tools, enablers, et cetera, that I have now, and where am I trying to go in terms of, do I want to add maternal and neonatal health onto this? And at what point do I want to do that? Next slide. But I think at the bottom of it, more importantly, it's thinking about who are the players that are going to be involved along this journey. Whether it's for a community health worker or a clinic worker, you can move the emphasis one way or the other. What are the real principles and design principles that I'm trying to work towards? Whether it's as I mentioned, establishing a clear career path, or optimizing access and system efficiency. And where are the elements where technology and the use of technology can play a role? In some places, it really just doesn't make sense. There are in other places where we can really see a clear change in in the way something could be done, or time saved or efficiency gained, or then it totally makes sense. And so you would, as a country, take this and look through and sort of do a diagnosis on your system. But it really needs, this kind of framework really needs to be paired directly with working with the end user, whoever that may be. And I'll leave it there. Thanks.
Thank you so much, Erica. I think that's a very fascinating look at particularly community health workers who provide a significant proportion of care and are able to take care to women rather than just waiting for women and newborns to come to care. So I think that's very fascinating. Okay, so we will now have our last panelist, Robert Miros from Third Stone Design.
All right. Good day to all of you. It's a pleasure to be with you. You can move to the next slide. So, as already mentioned by Rebecca Richards-Cordham, Third Stone Design is a company that collaborates with various entities involved in global health design and development. We are a private, for-profit corporation. We're based in the San Francisco Bay Area of California. And we engage in global health in a variety of different ways through systematic design and development, as well as distribution of medical devices. We do that in a number of different business models. Directly, we're currently engaged in developing refrigeration and pollution and respiration products of our own making. We also collaborate with both research and non-governmental organizations. I'll be presenting 3 examples of those types of collaborations today. And we also do sort of more conventional consulting and intellectual property work for specific needs within programs. Next slide. Today's discussion, I'm going to present 3 global health device development programs. They all are in the maternal and child health arena, which I thought appropriate for this conversation. They are the anti-shock garment, referred to as LifeWrap, a dose-right syringe dosing clip, and the Pumani BCPAP, which Professor Richards-Cordham has already eloquently described, so I'll go rather quickly through that one and talk about our role in it. Next slide. The anti-shock LifeWrap, as it's called, is a non-pneumatic garment that can be used for the emergency treatment of postpartum hemorrhage. So by applying pressure to the lower body and abdomen, the significant loss of blood following birth can be staved off in order for a patient to be moved from a tertiary medical setting to a more primary care setting where they can receive proper treatment. This is something that was developed by PATH. Many of you know of PATH, of course, based out of Seattle, Washington, with offices all over the world. They had identified this technology as a potential good solution for postpartum hemorrhage, and they had worked closely with researchers at UCSF, and in particular Sue Ellen Miller, who has been a champion for this therapy. The issue they had is that the particular device that was available at the time was overly expensive, quality was challenging, and most important was the ability to scale that solution. So Third Stone Design was engaged to find appropriate manufacturing partners for this particular device and to streamline the regulatory process around getting it cleared for use and sale around the world. We engaged in that project, did that sort of work by developing a detailed cost of materials, what we call bill of materials and cost of goods. Those are terms you'll hear in the supply chain world. Some detailed engineering drawings, understanding the specifications, materials requirements, really getting under the hood, if you will, on what made this product function from a mechanical standpoint. Went out, surveyed the world, found factories that were capable of making it, found, more importantly, business partners who were willing to take some risk in scaling up and manufacturing this device. Because of the nature of the funding for the program, we identified suppliers both in India as well as in China who were able to scale it, produce the device in a consistent, reliable fashion, in high volumes, and importantly at low cost, so that the impact of the device could be felt widely around the world by greater availability. One little lesson learned on this program is that just as product development can be unpredictable, and I think many of those on the call have been engaged in product development in one fashion or another, so too can clinical evaluations. So when managing a global program like this, it's important to keep tabs on how various aspects of that program are advancing in sync with each other to assure that when devices are ready, clinical results are ready, business plans are ready, all more or less at the same time, and that, of course, is a great challenge. Next slide, please. The dose-right syringe clip is something that was designed and invented in Professor Richard Kortum's program there at Rice University. It was in response to a need that was seen in Africa for delivery of antiretroviral medicines, essentially liquid medications that needed to be accurately dispensed. And Third Stone Design was engaged to improve the manufacturability of the device, basically to develop specifications. And then we ultimately ended up licensing the product, manufacturing it, and supplying the very first customer, which was the Clinton Health Access Initiative, who purchased actually a couple 100,000 of them for use in a mother-to-child transmission program in Swaziland. And the interesting thing about this program, I think, to highlight is that it's one of those solutions that you see it and you say, wow, why didn't I think of that? You know, it's just tremendously simple, very effective. And indeed, there was an initial customer, if you will, an initial application area, which picked up and moved with the device quite quickly, and that was exciting and certainly portended the potential for this application. Going since then have been a little slower, in part because we're requiring people to change in some ways their modalities for delivery and who might be delivering those medicines. So when you get into behavior change, as many of you will know, the best technology can sometimes sit and wait simply because it's not the way that they currently conduct their business. Next slide, please. Lastly, I'll go over quickly. We are engaged in helping the Pumani BCPAP product come to market. This was invented at Rice. Original design was done there, and we've been collaborating with the BDB program there at Rice for the past 4 years on this particular project. It's very exciting. We're attempting to, in quotes, do everything right, and even so, certainly we'll have challenges along the way. But I think the important thing to say here is that by engaging with us early, we were able to influence the design to continue to be low cost for the aims of the project and to be robust for field use. And we can scale it up in a fashion which is appropriate based on what is expected to be the market. And we can also tune that scaling to what the business probably can be. Next slide. So a few lessons learned here. One is that I would exhort all of you to be aware that your business model needs to be evaluated as much as your prototype. And by that I mean, I think we often, and we as engineers and designers here at our company are guilty of this. We get very enraptured with the technology and forget that it needs to exist inside a business ecosystem. Secondly, and part of that is to consider your manufacturing realities. It's important early on to be real about what is possible. Certainly it's okay to stretch and it's okay to dream, but to look askance or not to pay close enough attention to how something is going to be made effectively, both in low as well as high volumes, can put you into trouble later on when you can never achieve the cost of goods that you thought you would. You also need to map out your regulatory plan early. Sometimes what we're talking about doesn't require regulatory clearance or approvals, but if it does, make sure that you have a plan A and a plan B so that you can get to market eventually. As Professor Richard Kortum also noted, it is very important to bring users into your design and development. Many of us have been trained in that way, and we believe it thoroughly. I'd also tell you it's not enough to have people tell you they like your solution. You really need to understand if they would buy it, and if so, who would buy it. So that's a piece that can be difficult to tease out, but it is an important part of scaling a solution and making it sustainable. Finally, and I think many of the speakers have already echoed this, although these solutions are urgently needed, the best solutions do take time, and it takes time to implement things correctly. But if you do it correctly, the promise is that then we can have solutions that will scale and have as broad an impact as possible. Thank you.
Thank you so much, Robert. I think we've got an excellent, now well-rounded thought and a stimulated discussion, and there are some excellent questions that we've received. So I'll jump right into these questions. And the first question was being asked of Rebecca, but I think I'd like to hear all of you respond to this question, starting with Rebecca. This is a question from Prestige Tatenda Makanga, and she says, do you have examples of innovations that have been scaled up sustainably that do not have any commercial value, and what kind of partners have been involved in this scale-up? Start with Rebecca.
So innovations that don't have any commercial value.
Yeah, I think that she's probably describing that she's asking a question about whether we've got some really low costs that don't excite commercial manufacturers, perhaps.
So I think maybe if you look at the Medic Mobile, the text messaging system that was developed to help community health workers, first in Malawi and then in other locations, be able to communicate effectively from the field to central locations. I think that would be a good example of something where there's not a traditional business model of generating revenue, and it was development cost aside. It was something that was really cost effective to scale. That's the first one that comes to mind. I don't know, maybe others have other examples.
Okay, let me ask Robert.
Yes, in terms of, I'll be honest, as a for-profit company, we try to think of things that do have some potential for revenues. And frankly, I often evaluate if something can be sustainable if it does have some revenue portal. Certainly there are solutions related around nutrition that I can think of, the micronutrient world, which I won't profess to be any sort of expert in, but that do have sustainable distribution possibilities which aren't directly profit connected, I would say. So they can have an impact, they're very low cost, and the inclusion of them in food supplies oftentimes improves the offering of the manufacturer or the food producer, but in a way that doesn't necessarily drive up costs. So it's something that exists without a high level of added cost, and yet there's a tremendous benefit to it.
Fantastic. So Erica, do you want to comment on this from a UN perspective?
Sure. I mean, at the end of the day, most things do have some value and need some investment, whether it's, I think micronutrients are a great example. The investment is not necessarily in making money off of it, but there is a tremendous amount of investment in terms of getting the right partners on board, creating those partnerships, making sure that there is a sort of ready supply of these kind of micronutrients. I'd actually agree with the first comment sort of on the mobile health side. UNICEF has, at national scale, mobile health systems in about 6 countries now, where we're helping the government, working with partners, to put in place mobile health systems for which really focus on trying to ensure that we are supporting community health workers and sort of clinics in the last mile and in hard to reach areas. And I think because, and the way that they are sustainable is because we are not buying phones. We're using sort of technologies that people already have, very simple mobile phones, but we are paying for the sort of the transaction costs, so all the SMS costs and the voice costs. And we feel, and essentially we pay for it during pilot, but then it's something that the government takes on. And the reason the government can take it on is because it's not that much money. It's much cheaper to run an SMS and a voice program for year in and year out than it is to go out and collect data and sort of pay for that. So I actually think that there is if designed well and designed for scale and designed for sustainability, there is a great way which may not have a lot of commercial value. I mean, it has some commercial value to the mobile network operators because they're making some money off of it, but it's not necessarily any commercial value to someone else except for sort of the development of the technology, which is all open source. So I think that's a good example. I'm trying to think of What else? Yeah, definitely micronutrients. Even 10 years ago, or 15 years ago, a lot of the sort of vaccine manufacturers were getting out of traditional vaccines, and UNICEF and partners, whether it was Gavi, Gates Foundation, etc., really looked at how they could move countries from off of sort of monovalent single-dose vaccines, which were no longer profitable for pharma companies, onto sort of the multi-dose, sort of higher value vaccines. And so I do think that when we're thinking about really sort of public health goods, if they are becoming largely sort of unattractive to commercial entities, I do think that there is really a job around market shaping that a lot of the big sort of organizations and donors need to think about doing as well.
Thank you, Erica. Jeff, do you wish to make a comment on this?
Just very briefly, one thing for us to keep in mind is that innovations don't have to be things that have a cost. They can be processes, and processes. I can't come up with one that comes to mind right now, but processes are things that can really help us to improve our work, improve the flow of information, improve performance, and that can be sustained well without having to engage a commercial partner or make a profit.
Thank you very much. Let me just contribute as well. I think there are some pharmaceutical technologies, for example, that have almost no chance of getting universally made available in countries. Magnesium sulfate, which is very inexpensive, is facing some challenges in some countries because commercial entities do not see a profit in marketing that particular product. And I think so we really do need to find a balance between trying to get things that are extremely low cost and things that are commercially viable. All right, let me take the next question, and I think again this question would probably be for everybody. So here's a question from Sage Innovation on failure. How do we raise the tolerance of our partners and donors to failure? And let me add also, I'd love to hear from each of you an example of a failure that you've been personally involved in, and what have you learned from it? What are the critical insights that you got out of that failure? Let's start with Robert. Why don't you go first?
Of course, it's tempting to say we don't make mistakes. But last year, one of the takeaways at the end of our sort of business wrapping up was about trial and error. And one thing I suppose I'd say to anyone who's trying to encourage failure is that it is a process of learning. You're bound to make missteps, and that error rarely feels good. And I think that's a natural human reaction. And so there's certain things that can be done in terms of encouraging it to embrace it and recognize it as an opportunity for improvement. That said, I'll be honest, we as product developers and designers do engage in lots of activities which certain things don't necessarily get beyond the drafting board or beyond the sketchboard or beyond our prototyping shop, or maybe they do get out into the world and we learn quickly that they're bad solutions and we adjust and move from that. Rarely do I categorize those things as failures and instead see them as a process of learning and continuous improvement. So that may be the one thing to say about embracing it, is to see it as continually improving and making better. We have, as a personal example, as I mentioned, we are engaged in developing some portable refrigeration systems, and we're now on our third significant iteration of that same concept after being engaged in the activity for 7 years. So it's not a quick road, and two significant development efforts with a fair amount of funds put behind them and a lot of talent essentially didn't really see the light of day simply because they just didn't work the way they were supposed to. I can get kind of schadenfreude about that because they were significant efforts, but we're now on our third effort and it's working out really well because we took all the learnings from the first two exercises. So perhaps it's a terminology problem, or perhaps it's a reputation problem. As I said, we think about it as continuous improvement and continuous opportunities. for learning as opposed to simply failure.
Very good. Okay, so Rebecca?
Sure. So I think the example that I'll give is actually the dose-right example, and Robert showed in his talk the final product, but before that there were a couple of other generations of solutions to that problem of improving the accuracy of dosing liquid medications. And the very first one, it looked like a hand pump bottle of lotion where you would press down a plunger that then would draw medication up into this chamber that could be metered. And the students loved this solution, and then when they took it to the field, every single user said they hated it. It was hard to use. It was hard to clean. They didn't like anything about it, and it was very depressing for the students that were engaged in the design. But when we were able to show that device to other teams of students, there's something about sort of seeing tangibly a solution that doesn't work and hearing what users say about it that is very inspirational. I think it's inspirational in a way that's really different than writing down the constraints that a solution has to satisfy. And so we've learned to use those early failures as inspiration tools. And I think the power of them really sort of surprises me. And then I think the other thing that we've learned about dose-right is, initially we thought its primary use would be for dosing liquid antiretroviral medicines for newborns who are part of PMTCT programs. But one of the things we've learned from listening to users in the field is that there's a huge role for that, potentially in palliative care in low-resource settings for improving accuracy of dosing liquid morphine. And so we sort of learned to look for other opportunities for products where maybe the initial intention for them, it either the scenario changed or maybe it wasn't quite the right solution, to learn to shop it around and see where it might be useful. So just always listening like that.
Thank you. Erica, on the issue of raising the tolerance of partners and donors to potential failures and recognizing failure as a pathway to success, what are your thoughts?
Well, I think we completely embrace failure in my team. We fail all the time, and I would say that we probably fail 90% of the time, which is totally fine because it's the way that we get to success. And we actually have something called Fail Fridays where the team gets together every Friday and we talk about one thing we failed at, one thing we succeeded at, and one thing that confused us that week. So we really try to build it into the culture, not just to, celebrate your failures, but also really learn from them and move on very quickly. I think this sort of large-scale planning and thinking that things aren't going to change is sort of the surest way to long-term failure. And I think agility and really being able to have your work be influenced by others is much more the pathway to success. I can think of sort of anything that we've ever tried to design from not with the end user has failed. And I think a perfect example of that is a project that we did with a bunch of partners called Our Stories, which was trying to get young people to record their stories and put them up online. And the reasons we failed were because we didn't really know who our users were. We didn't know why they would want to put their stories up online. We didn't know, really understand, the devices that they would be using to do that. But sort of a different incarnation of that, which is now called U-Report, is running in 4 countries. In Uganda, it has 280,000 young people online who are answering questions every week. So we say, it's a similar thing. It's getting the voices of young people heard at the highest level of government, but it's a sort of a very different implementation of it. And I think that took us 2 or 3 years to figure out what it was actually going to look like. and what was going to make it successful. So, I mean, I'm going to stop there, but I can give you many, many, many examples of sort of personal failure in our team.
Thank you, Erica. And Jeff, from your perspective, from an implementation perspective, what can we do better at the design phase that would make implementation go much smoother from a failure perspective?
Well, I think what's important is that we ensure that we're gathering data all along the way. We had a bit of a failure in our misoprostol program in Liberia, where the decision was made at the beginning to use a certain implementation approach, and that implementation approach allowed us to only get to about 27% of home births covered with misoprostol, and that was remarkably less than what we'd achieved in other places where the coverage was 90% or better. But because we had the data, and because we had designed our approach in order to collect that data so that we knew what was working and what wasn't, the ministry was able to learn from that, and the donor was able to learn from that, and we were able to design a new strategy that was more aligned with hopefully achievement. So I think making sure that we have the data so that we can learn along the way is fundamental.
Oh, thank you very much. Now, here's a question that came from Brennan. For Rebecca, how did you balance inputs from different customers? Users and health systems may have very different things that they want.
So we tried to look for segments where the needs are similar, and I think CPAP is a good example of that. The CPAP device that we have designed is really designed for facilities that don't have wall air or wall oxygen. And for facilities that do have that level of infrastructure, there may be other solutions that are a better match. And there are good examples of other programs who are developing solutions like that, PATH, for example, or East Meets West. And so I think looking for the settings where users have common needs and trying to connect those, I think that's one approach to that. I think the other is you are sometimes going to get just conflicting advice, and sometimes it's only trying it out that's going to give you the real answer. And again, with CPAP, and our device, we chose not to heat or humidify the mixture of pressurized air and oxygen that's delivered to the babies. And I have to say there were a lot of neonatologists who told us that that would fail. It would just never work without that. And then our approach instead was to provide nasal saline drops for the babies. And in many ways, I think that was one of the most important findings from the initial pilot clinical implementation we did, was that the nasal saline drops seemed to work just as well as heat and humidification in terms of reducing some of the complications if there's airway drawing. And only data was going to settle that question. So I think it's important to sort out where do you need more data to sort out those differences, and where is it truly just something that relates to different needs.
Thank you. So next question is for Erica Kochi from Richard Lowe. I like the quote that job aid is the Bible. How does this need for simple, often paper-based systems sit in the development world when the current focus is often on gadgets and mobile phone applications, many of which may not actually address the problem?
Yeah, I mean, I think that when you're designing solutions, technology solutions, you can't think of technology as a silver bullet. It's really not. It's not even. It's probably 1% of a potential solution. All of the other things around it are, whether it's sort of the relationships, the partnerships, the training, the policy are the largest part of it. And one thing I see in the public health world, which really kind of just really annoys me is people either think that technology is going to solve all their problems, or they're so adverse to try it and they just think it's a gadget. And I think that it's definitely not a gadget. But we need to apply it usefully. And don't think that we're going to transform health information systems overnight. So a lot of the work that we do is look at how mobile technology can help supplement and make delivery of services stronger. So it's not a replacement, but it's looking at, we know that the job aid is vital, and we know that, community health workers never get any feedback, usually on how they're doing. They're not using their own data, and it's not fed back to them. Maybe the form factor of the job aid is not quite right. So we need to think about how we can strengthen what we already know is sort of the Bible of community health workers into be something more meaningful and sort of more useful to them. So again, it's sort of really taking that user-centered approach of looking at what they're doing now, what could help them, what probably they should be doing less of, and look at, pair that with the kind of results that you want to achieve. And so I don't think that it's a either or. I think you have to do both. We have this opportunity now. We have a two-way communication device in most people's hands, around, especially community health workers' hands around the world, and we need to use it, but we need to use it carefully. Someone coming in, I think the thing as public health people you need to be the most wary of is when people come and try to sell you a technology. They're trying to sell you a solution when they don't even know what the problem is. I really think you need to go through the process of trying to figure out what your problem is and look at where technology could help solve it. And in many places, it's completely not appropriate.
Excellent. I think that leads us to the next question, which from Nikhil Patil. I think this is for everybody, but let me ask Robert to kick off this thing. The question is, when it comes to design, where do you start? Whether your end goal is a product or a platform or even a delivery system?
Okay. Well, typically, Rebecca referred to shadowing, and that is often where we start, which is what is the particular situation in which we're working, doing some need finding, identifying what those particular situations are that the user encounters in the practice of their work or in the administration of their job, and identifying needs. And those needs can be device-related, they can be systematic, they can be process-oriented. But by identifying those needs and making lists, we oftentimes refer to them as bug lists, things that bug people, that bother them, and then trying to basically coordinate those needs with technologies with which we're familiar or processes. To Jeff's point earlier, it needn't always be a gizmo. And between the two, sort of the nexus between the need and solutions we're aware of, coming up with good answers that could manifest themselves as products or as defined processes which could be delivered. Sometimes we also are coming at it, admittedly, from the other direction, which is we sometimes have technologies which we think have great promise, and then we go out and we identify how those technologies could be morphed or modified or updated or improved to be appropriate for known need areas. So we needn't always start out in the field, but oftentimes we end up there pretty quickly.
Thank you, Robert. Jeff, do you want to comment on this?
I think Robert's points were well taken, that I think we need to really start with understanding what is challenging people, what are the questions that they struggle with, what would make their job easier. And I think it's multidimensional, and our approach has to be multidimensional. We have to ask at every level of the system and really strive to get perspectives from people at multiple levels along the development process.
Okay, thank you. All right, so another question now from Tracy Rosen, and this is on the bubble CPAP. For the CPAP machine and more widely, how are repairs and machine maintenance, if needed, carried out? In Malawi, it sounds like there is a polytechnic university, but other countries may not have such availability. Start with you, Rebecca.
Yeah, so developing training programs for local biomedical technicians to be able to repair them is something that I think is really critical to support the scale-up of that technology. And I think that the device was designed so that it could be maintained locally. That was something that we worked really hard from the beginning to be able to incorporate into the design. And we're certainly learning from our field implementation experience about what worked well and what needs to be further improved. I think that's an area where field experience is one of the most important ways to learn if you've got it right or not.
Good. Anybody else wants to comment on this?
This is Robert. I'll just add that Rebecca's entirely right. That you don't learn much sitting in your lab. You can learn a lot by testing things, and she already made that point, but you learn a tremendous amount more once devices are out in the field. It's also important to do that sort of rollout in a measured way where you can have good eyes and mechanisms to understand what might not be working or what might be failing from a component level on a system to be able to assess that and improve. Lastly, in relation to the CPAP directly, an interesting thing we've done with it is include spare parts for maintenance with the device when it ships. So we presage that there are some components that will wear out. We provide instructions on how those components can be replaced. And we're developing systems and process that will allow for that sort of maintenance to be tracked and understood in a longitudinal way so that when we identify a device 3 years from now, we can know what has been replaced, what has been adjusted, what revision they're on. So it's a fair amount of engineering control and process documentation. But I'd also just say it's one of the great challenges for hardware, specifically in these developing country contexts, that the amount of available technical support and maintenance it depends entirely on where you are. And someone mentioned the Polytechnic being in Malawi. That is true. You get not too far away from the Polytechnic and you'll not have nearly as much technical resource. So systems need to be designed to be robust to begin with. And then I think there needs to be an understanding that things will break and that they can be fixed simply. And finally, you need a method for understanding those issues that arise so that successive generations of product can be improved and made better.
Thank you. So here's a question for Jeff on prenatal care. I think prenatal care has suffered in recent times because we focused, or the global health community focused, very much on care at birth. If we were to change the design of prenatal care services, what key features would you consider?
Thanks. I think prenatal care or antenatal care is a process, and so I think we need to think about process innovation as well. I think one of the major issues is the potential for overwhelming the health system and the health workers who are there, because there has to be if we're anticipating that they will do more, like test for HIV and provide nutrition counseling and begin discussion of family planning for immediate postpartum provision, then we're asking more of that health workers. So I think we need to consider process innovations. And sometimes that is some of the simple things of, mapping the delivery of care. I was speaking to colleagues recently who simply went into a facility and had the providers walk the same path that a woman would walk if she were to get her blood pressure checked and her weight measured and then a blood test, etc. And they realized that she went to 8 different places in the facility. So sometimes the innovations that we're looking for are process innovations. At the same time, I think if we can develop some of the technologies that were presented earlier about on-site diagnostics, that's going to have a major impact because the challenge with antenatal care is women often come from a distance, and being able to give them immediate information and change treatment plans on the spot is fundamentally important. So I think thinking about processes and thinking about the immediacy of that clinical encounter is going to be fundamentally important.
Thank you, Jeff. One last question here from Phyllis Clark. This is regards to the CPAP device. Availability of continuous electricity is a huge issue in developing world. Is there a built-in battery backup for the device? And if not, how do we handle, in general, the issue of power?
So this is Rebecca. There is not currently a battery backup that's included as part of the device. And so in cases where the power does go out, then the nasal prongs are removed until either power comes back on or until generator power is able to be provided. I think because this does require AC current to run the pumps in the device, providing a battery backup is not it's not easy to do without significantly increasing the cost of the device. And so I think this is a technology where rather than adding battery backup to the particular technology, it really makes more sense to think about how do you strengthen the supply of electricity to the neonatal ward. I think there are other types of technologies where it's more cost effective to provide battery backup. I don't know, Robert, if you maybe have an alternative perspective as the maker.
Right. The decision not to include batteries was a conscious one, in part because it adds a tremendous amount of expense to the system. It introduces another failure mode, frankly, because now there's a charging circuit, there's batteries that have to be maintained. And so in trying to keep things simple so that they can last longer, it's a certain thing that we removed such a power supply. Having said that, Rebecca's dead on that points to perhaps a bigger need. There are other devices in these neonatal wards that also require power. Trying to address that problem on a clinic basis or on a ward basis or even just a room basis is probably a better solution than trying to put batteries in everything. Having said that, there are going to be situations where battery backup may be required, and it might be better done through a adjunct piece of equipment that could sit outside the device, and that would, of course, then have with it added cost, but it would only be included in those situations where it was identified as required. In the bigger context, we understand power is a challenge in many environments, and I would sort of exhort all device developers to think about what intermittent power and varying levels of power can do to your devices, because I think it's an assumption sometimes that things are just on or off and not that they might be running at partial power or overpower situations. So just a note to the group that it's not just that the power goes out, it's that the power's inconsistent, and that can have as much of a issue and a challenge for products as simply it being off.
Yeah, I mean, just to add to that, one concrete example from our implementation work is that along with the CPAP devices, we provided oxygen concentrators. And the oxygen concentrators, of course, were sourced commercially. And we have had significant failure rates of the oxygen concentrators because the line voltage fluctuations damage the circuit cards in those devices. Whereas the CPAP device, which utilizes only analog electronics, we have not experienced any such failures because of those line voltage fluctuations. So really designing for these poor power quality issues is just critically important.
Right, and I will add that we've seen many graveyards of very fine equipment lying around in developing countries that have largely been damaged by power brownouts or power surges. Okay, so I'd like to give each of you 1 minute to make a final comment, one really key take-home message. And let me start with Erica. Erica, your take-home message.
I mean, I think I've said it before, but really at the design phase, your user is key. If they don't see value in the system and they don't see value in using it in terms of helping their life, their day, their work, then you're sort of fighting a losing battle.
Okay, and Robert, one key take-home message?
Yes, so I think I'll just come back to the note that there are good resources available now for design and development, for product design and development. And I would just encourage everyone to include in that business considerations, regulatory considerations in the manufacturing side, if they hope to reach the scale and impact that they originally set out to address.
Thank you, Robert. Rebecca?
I would make a pitch for really thinking about integrated solutions, because I think that's going to be the key to really improving outcomes, is to think about what are the comprehensive needs and to what extent can technologies address that, to what extent can training and processes address that. And I think equally important is integrating the needs for maternal health and the needs for newborn health, and making sure that we aren't letting the babies fall through the cracks between those two areas.
Thank you. And Jeff?
Yes, I think I've mentioned it already. I think product innovations are fundamentally important, but I also think that process innovations are important. I think they allow us to do our work more effectively and more efficiently. I think providers often look for these kind of process innovations, and I think they may be closer to allowing us to solve the question of data, so that we have data to be able to understand our impact and whether or not we're achieving what we set out to achieve. And that need for data in maternal and newborn health is a fundamental issue that's going to drive a lot of our work in the next 10 to 15 years.
Okay, well, thank you very much. I think I believe that the panelists have provided us some very stimulating thoughts for us to think about. And let me thank all of you and then hand over to Brennan.
Great. Thank you to all of our speakers and to the audience for sticking around. I know that this was a really great discussion and with some very important lessons. We know we didn't get to all of the questions and comments from the audience and from the panel, but please do follow us on Twitter at Jhpiego for more exchange of ideas and opportunities and connecting with other thought leaders in the field. Just wanted to summarize some of the lessons that we heard today. One, I think, that emerged from the panel is it's never too early to start thinking about the health system and implementation environment, as well as the realities of manufacturing and the business model. But all of those are very important considerations very early on. The second lesson, I think, is scale and implementation takes a lot of time. So the more we consider that and take on those kinds of partnerships and interactions with those in the implementation and advocacy communities, those can influence design and development decisions in a very important way. Related to that, I think, is we should all take comfort in the notion that no single organization should be expected to take a technology all the way through. The more innovators and implementers can come together, I think the greater likelihood for success. So a very important theme, I think, that emerged from this, from all the panelists, is that technology is not in itself a solution. It may be part of a solution, and that integrated solutions, both across health systems and across maternal and newborn health challenges, are what's really important. So given some of the health challenges ahead of us, and as those that Jeff Smith articulated, where we can strengthen the platforms of services and clinical provision, antenatal care, perinatal care, postnatal care, process innovations as well as technology innovations are really important to improve the clinical encounters as well as the health outcomes. So just wanted to remind those participating that we have 2 more webinars in the series. The next one is on this coming Thursday at 10:30 called the LEAP webinar. We'll have some practical considerations about generating confidence and evidence in the product development process in field research and in commercialization. And then next Tuesday we'll conclude with the Deliver webinar to address aspects of scale and introduction. So thank you again to everybody. Please visit us on jhpiego.org and on Twitter at InnovateJhpiego. We'll continue to address some of these with the community and try and connect some of the thought leaders and opportunities that exist out there. Thanks so much.